morning. My name is Kristin Marks. I am an Epidemic Intelligence Service Officer assigned to the Maternal, Infant, and Toddler Nutrition Team at the CDC. Thank you for the opportunity to share our team's work on breastfeeding and the Maternity Practices in Infant Nutrition and Care Survey with a focus on Georgia. During this presentation, I will share some background on breastfeeding and hospital practices, and I'll spend most of our time together discussing the Maternity Practices in Infant Nutrition and Care, or mPINC survey. Our objectives for the day are to describe current rates of breastfeeding and the importance of hospital practices on breastfeeding outcomes, compare Georgia and national results from the 2020 mPINC survey, and determine areas for improvement in maternity practices in Georgia, and identify ways to use mPINC scores for improvement. We'll begin with some background on breastfeeding, including breastfeeding rates in Georgia in particular. Breastfeeding offers health benefits for both infants and mothers. Nutrition during the first 1,000 days is critical for growth and development. Breast milk provides optimal nutrition for most infants and offers protection against many illnesses and infections, such as asthma and ear infections. In addition to promoting bonding between mother and infant, breastfeeding also provides health benefits for the mother, including decreased risk for some chronic diseases, such as high blood pressure and type 2 diabetes. Because of breastfeeding's numerous benefits to both the infant and mother, the Dietary Guidelines for Americans, the American Academy of Pediatrics, and the World Health Organization recommend exclusive breastfeeding for about the first 6 months and continuing breastfeeding with the introduction of complementary foods until at least the first or second birthday. It can continue longer as mutually desired by mother and infant. Our team uses the National Immunization Survey, or NIS, for national breastfeeding surveillance. NIS is an annual, nationally representative survey conducted by the CDC using random digit dialing. While its primary objective is to assess vaccine coverage among children, questions on breastfeeding are asked to caregivers of children aged 19 to 35 months to assess breastfeeding rates at national and state levels by birth year. The responses to these questions allow us to track breastfeeding initiation, breastfeeding duration, formula supplementation, and exclusive breastfeeding, which I'll now discuss. So to orient you to this table, I have put the various breastfeeding indicators across the top of the table, and the 2 rows show national rates and Georgia-specific rates. Here we see that 84% of infants nationwide are ever breastfed, while 81% of Georgia infants are ever breastfed. The difference between the US and Georgia widens to almost 4 percentage points when we look at breastfeeding at 6 months of age, where 52.9% of Georgia infants are breastfed. When we look at breastfeeding at 12 months of age, more Georgia infants are being breastfed than the national average, with 36.2% of infants breastfeeding at 12 months in the state of Georgia. Now I'd like to focus on exclusive breastfeeding. Under 44% of Georgia infants are exclusively breastfed at 3 months, which is almost 3 percentage points below the national rate. The difference isn't as wide when we look at exclusive breastfeeding at 6 months of age, with a little over 24% of Georgia infants being exclusively breastfed at 6 months old. Lastly, we see that just under 19.5% of infants nationwide and in Georgia receive formula before 2 days of age. This figure shows in a little more detail what we just discussed. Nationally, rates of any and exclusive breastfeeding decline as infants age, with only 25% of infants being exclusively breastfed at 6 months and 35% being breastfed at 12 months. For each birth year, we calculate the percentage of infants ever breastfed and breastfed at 6 and 12 months, as well as exclusively breastfed through 3 and 6 months. Our surveillance indicates that US breastfeeding rates do not meet recommendations of exclusive breastfeeding for about 6 months and continuing breastfeeding until at least 12 months. However, rates have been steadily increasing over the past decade. I'd now like to share breastfeeding initiation rates by race, which were calculated using 2019 birth certificate data. This table uses a similar format as we saw before, with national breastfeeding initiation rates in the first row and Georgia-specific rates in the second row, with racial and ethnic groups across the top. So, looking within the race ethnicity columns, Georgia outperforms the national average in all racial and ethnic categories except white. But that being said, almost 94% of Asian women in Georgia initiate breastfeeding, while only 77% of Black women in Georgia initiate breastfeeding, which is a 17 percentage point difference, indicating racial and ethnic disparities in breastfeeding initiation within the state, and there's a similar trend nationally. So to see how Georgia compares to other states in this regard, we can look at this map, which shows the largest disparity in breastfeeding initiation between racial and ethnic groups by percentage point difference. And as we discussed, there is a 17 percentage point difference in Georgia, and this map shows states with greater disparities in darker colors, and we can see that there are sizable disparities in breastfeeding initiation between racial and ethnic groups in other parts of the South and Midwest. So I've just shared a lot of data about breastfeeding initiation and duration, but let's talk about breastfeeding intentions. Most mothers want to breastfeed, but stop early due to a lack of ongoing support. 60% of mothers stop breastfeeding sooner than they planned. Certain factors make the difference in whether and how long babies are breastfed, including hospital practices, education and encouragement, policies or supports in the workplace, and access to community supports. I'll now talk in more detail about the importance of hospital practices in supporting breastfeeding. Hospital practices in the first hours and days after birth make the difference in whether and how long babies are breastfed. The WHO-UNICEF Baby-Friendly Hospital Initiative is the global standard for hospital care to support breastfeeding, with the 10 steps to successful breastfeeding at its core. The percentage of U.S. hospitals implementing the 10 steps has increased. In 2000, less than 1% of U.S. births occurred in approximately 60 baby-friendly hospitals. By 2018, these numbers had risen to more than 25% of births in more than 500 baby-friendly designated facilities. In Georgia, 31% of live births occurred at baby-friendly designated facilities in 2018. Hospitals influence how the nearly 4 million U.S. babies born each year are fed. Further improvement in hospital practices could increase breastfeeding rates and contribute to better child health. Successful breastfeeding is influenced by the experiences soon after birth. These experiences impact both the mother's and the infant's ability to continue breastfeeding after they are discharged from the hospital. As outlined in the 2011 Surgeon General's Call to Action to support breastfeeding, early initiation of breastfeeding is negatively impacted by many health services-related barriers, such as low priority given to breastfeeding by many maternity care staff, insufficient knowledge and clinical competence among clinicians, fragmented care, inappropriate routines such as distribution of gift packets containing infant formula, and inadequate hospital facilities that may not allow for practices such as rooming in. Results from systematic reviews and meta-analyses show that maternity care practices supportive of breastfeeding, as demonstrated by adherence to the Baby-Friendly Hospital Initiative's 10 steps for successful breastfeeding, are associated with improved breastfeeding outcomes. Results also show a dose-response relationship between the number of baby-friendly practices experienced and the likelihood for improved breastfeeding outcomes. Baby-friendly practices may also help to decrease racial and ethnic inequities in breastfeeding outcomes. And lastly, adherence to the 10 steps may not significantly increase hospital birth costs. Now we'll talk in more detail about the Maternity Practices in Infant Nutrition and Care, or mPINC survey. First, I'll give some background on the survey and discuss its methodology. Some of you are probably familiar with mPINC, but for those who are not, I'll give a brief overview. mPINC is CDC's national survey of maternity practices in infant nutrition and care. The survey measures care practices and policies that impact newborn feeding, feeding education, staff skills, and discharge support. The mPINC survey launched in 2007 and was administered every 2 years through 2015. In 2018, the survey was redesigned with new questions and scoring, so results from 2018 and beyond should not be compared with previous years. In 2018, the survey was also moved to web-only participation, and it no longer includes freestanding birth centers. All hospitals in U.S. states and territories with at least one birth in the past year are eligible to participate. The survey assesses infant feeding-related maternity care and practices and policies. Response rates have ranged from 70 to 83% across years. The mPINC survey covers several topics or domains of care, including immediate postpartum care, rooming in practices, feeding education and support, discharge support, and institutional management. Responses are scored using an algorithm that denotes the evidence-based best practices to promote optimal infant feeding in the maternity care setting. Possible scores range from 0 to 100 overall, and for each domain, with higher scores indicating better practices and policies. Information on how these domains are scored can be found on our website, which I've linked at the bottom of this slide. I'd now like to present some mPINC results. We are excited to share the results of our recent 2020 survey. In 2020, 2,103 hospitals participated in mPINC out of 2,810 eligible hospitals for a response rate of 74.8%. This table shows the response rates for mPINC 2020 by state in alphabetical order. As you can see, Georgia had one of the lowest state response rates in 2020 at 55.8%. There were 43 out of 77 eligible hospitals in Georgia that participated. Now I will share some results from the 2020 mPINC data. Of note, survey respondents are asked to report on their practices for the previous year, so 2020 responses should reflect practices in 2019 before the COVID-19 pandemic. This figure shows the national mPINC scores from 2018 in blue compared to 2020 in green for the total score and 6 subdomain scores. The 2020 total national score was 81. This was an increase from 79 in 2018. And all domain scores showed modest increases in 2020, except the feeding practices domain, where the national score stayed the same at 82. The domain with the highest national score was feeding education and support at 93, while the lowest was institutional management at 71. In the next several slides, we'll look a bit closer at the 2020 scores by state. And for each map, state scores were calculated as the average of scores for all participating hospitals in the state. These were color-coded as shown in the key, with darker orange indicating higher scores and lighter orange for lower scores. The first map presented shows total scores for 2020. The national total score was 81 and Georgia's total score was 75. For the immediate postpartum care domain, the national score was 83 and Georgia's score was 74. The immediate postpartum care domain includes items like skin-to-skin contact after birth. The national score for rooming in was 76. Georgia's score was 68. The rooming in domain includes items on separation of infants from mothers for procedures and rooming in safety protocols. The feeding practices domain national score was 82. Georgia's score was 75. This domain includes items related to formula feeding of breastfed infants. As mentioned, the feeding education and support domain had the highest scores, with a national score of 93 and Georgia's score was 90. This domain includes items like identifying feeding cues and breastfeeding problems. The discharge support domain national score was 79 and Georgia's score was 73. The discharge support domain includes items like scheduling follow-up visits and gifting of formula and related supplies. Institutional management was the domain with the lowest national score of 71 and Georgia's score was similar at 68. The institutional management domain includes assessment of staff competencies and acquisition of formula. We've just taken a look at some national data, and now I'd like to take some time to focus on Georgia data in particular. So we can see that the state's total score rose 2 points between 2018 and 2020, which is on par with the national increase observed over the past 2 years, but Georgia's response rate remained low at 56%. We can look more closely at how the domain scores have changed over time. We see that the increase in Georgia's total score was largely driven by a 7-point improvement in rooming in and a small improvement in the institutional management domain. All other domain scores remained the same or decreased by 1 point over the 2-year period. And while we just saw a small increase in mPINC score from 2018 to 2020, I want to show some more data from the National Immunization Survey that shows how small differences can add up over time. Here I present 10 years of data on any and exclusive breastfeeding in Georgia. In the figure on the left, you can see that for infants born in 2009, 66% were ever breastfed. By 2018, 81% of infants were ever breastfed, for a 15 percentage point increase. The gains were even larger in breastfeeding at 6 months, with a 17 percentage point increase over the decade, and breastfeeding at 12 months, with a 21 percentage point increase. In the figure on the right, we can see that exclusive breastfeeding rates have also gone up quite a bit. For infants born in 2009, about 25% were exclusively breastfed at 3 months. 10 years later, for infants born in 2018, almost 44% were breastfed at 3 months, for a 19 percentage point increase. Again, I just want to reiterate that improvements are being seen in Georgia. I'm hoping the data presented in the next section start to give you ideas on what more could be done to continue this positive trend, particularly in the birth hospital setting. Now we will look more closely at each subdomain in 2020, comparing Georgia and national results. In these slides, I will compare the national and Georgia subscores and point out items where Georgia is 10 percentage points or more below the national average, as well as items where Georgia is above the national average. Things might go a little fast, but all this information will be available in the national report and Georgia State report for mPINC 2020. First up, we have the immediate postpartum care domain. Georgia's subscore is 9 points lower than the national subscore, and we see some of the biggest differences in skin-to-skin contact following vaginal and cesarean deliveries, as well as monitoring immediately after birth. For the rooming in domain, we see Georgia's subscore is 8 points lower than the national subscore, and the biggest differences are in 24 hours a day rooming in and having a protocol for frequent observations of high-risk mother-infant dyads. For the feeding practices domain, we see Georgia's subscore is 7 points lower than the national subscore, and Georgia could use improvement in counseling breastfeeding mothers about the possible consequences of infant formula. For the feeding education and support domain, both Georgia and the national average subscores are high at 90 and 93. Georgia is below the national average in the formula feeding techniques and safe preparation item. For the discharge support domain, Georgia is 6 points behind the national subscore. Areas for improvement include a discharge criteria of effective feeding of breastfeeding newborns, and not giving mothers gifts or free samples of items like infant formula. I also wanted to point out areas where Georgia is exceeding the national average, and so by the thumbs up symbol, we see that Georgia does well with scheduling the first follow-up for breastfeeding newborns as part of discharge criteria. Georgia is just slightly behind the national average for the institutional management subscore, and there are no items where Georgia is 10 percentage points or more below the national average. There are a couple items, hospital purchasing of formula and written policy elements, where Georgia does better than the national average. So in the previous slides, I compared how Georgia was doing relative to the national average of mPINC scores. Because of several different factors, it might not be fair to compare Georgia to the nation as a whole. So here I'd like to provide some key takeaways from mPINC with a focus on the absolute scores. In terms of strength, more than 80% of Georgia hospitals already have the ideal response for 5 different measures. 1, not separating mother-infant dyads before rooming in after vaginal delivery. 2, not performing routine blood glucose monitoring on newborns who are not at risk for hypoglycemia. 3, scheduling the first follow-up with a healthcare provider as part of discharge criteria for breastfeeding newborns. 4, supporting breastfeeding mothers through in-person follow-up visits and appointments, personalized phone calls, or formalized coordinated referrals to lactation providers as part of discharge support. And lastly, tracking exclusive breastfeeding throughout the entire hospitalization. Moving over to areas for improvement, the top priority has to be increasing Georgia's response rate to the mPINC survey. It's hard to know what's going on in the state when only a little over half of the hospitals respond. There are 3 areas where less than 40% of surveyed hospitals have the ideal response. First, there is room for improvement in conducting routine newborn exams, procedures, and care in the mother's room. Second, there is room for improvement in provision of infant formula to healthy breastfeeding newborns. And lastly, having written policies in place around breastfeeding support is a potential area for improvement for many hospitals. So I'd like you to remember that one of the benefits of mPINC is that it functions as both surveillance and an intervention. We provide individualized reports to each hospital, showing their total and domain-specific scores. We also provide them with average scores among facilities of similar size, in the same region, and among all participating facilities for comparison. We're happy to share that all mPINC 2020 hospital reports were sent out by email in August 2021. CDC also releases state-level reports showing average scores from all participating hospitals in a state that year. This is an example of a 2018 state report. At the time of this recording, the 2020 state reports have not yet been added to CDC's webpage, which I've linked at the bottom of this slide, but we expect them to be posted very soon. The National mPINC report provides an overall picture of maternity care supportive of breastfeeding in this country, and will also be available for download on our webpage soon. So I'll now talk about how some states have used mPINC for improvement, which I think will be of interest to this group. What I'm about to present is nicely described in the paper I've referenced here by my colleague, Dr. Jennifer Nelson. States such as California and Minnesota have used their state-specific mPINC data to develop more targeted data reports. For example, the California Department of Public Health created region-level mPINC benchmark reports. Similarly, the Minnesota Department of Health WIC program created region-specific mPINC scores, allowing for a better understanding of regional differences in hospital practices. There are many state-specific recognition programs designed to acknowledge hospitals for implementing a portion or all the 10 steps. Based on our work with state health departments, breastfeeding coalitions, and other stakeholders, we are aware of a handful of states that use state-specific mPINC data, along with other breastfeeding data, to inform their recognition program, including reporting of mPINC participation and/or total score. For example, the Kansas Breastfeeding Work Group has used Kansas's mPINC data to monitor progress towards implementation of their High Five for Mom and Baby program, which helps hospitals adopt 5 evidence-based breastfeeding-related maternity practices. Also based on our work with breastfeeding stakeholders, we are aware of states that have used their mPINC data to inform or highlight their breastfeeding work. For example, the Hawaii State Department of Health, their Healthy Hawaii initiative, was able to monitor progress of the Baby Friendly Hawaii project, which aimed to improve evidence-based maternity care practices and in-hospital exclusive breastfeeding rates by monitoring pre-project and post-project mPINC scores. The mPINC data have played a role in state and county-based quality improvement initiatives in places such as Iowa and Tennessee. An example of states working with individual hospitals is the Iowa Department of Public Health that realized, prompted by the state's mPINC ranking, that women delivering in rural hospitals did not have the same access to breastfeeding education and support compared with other women. In turn, Iowa set up breastfeeding education training targeted at staff of rural hospitals with a significant number of Medicaid births, which resulted in a majority of hospitals implementing at least 3 of the 10 steps. To further this effort, Iowa offered targeted technical assistance to select hospitals which had mPINC scores lower than Iowa's total score in an effort to identify where improvements could be made. Another example of state-level quality improvement is how Tennessee developed a breastfeeding toolkit in which resources to help hospitals improve their breastfeeding practices were organized by the mPINC domains of care. States like New York and New Mexico have also used the mPINC survey as a basis for or in comparison with their own hospital assessment tools. The New York State Department of Health conducted their own maternity care practices surveys in 2009 and 2014. Though there were slight differences between the surveys, both were able to measure a consistent increase in the statewide composite score, demonstrating improved maternity practices. The New Mexico Breastfeeding Task Force created their own hospital-specific report cards, which, similar to the mPINC hospital reports, provided hospitals with a comparison of their breastfeeding performance to all New Mexico facilities and facilities of similar size. I also want to give you a taste of how states can encourage hospitals to review their mPINC data to make quality improvement changes. Facilities have used the subdomain scores and percentile rankings in the hospital reports to identify areas to improve the maternity care they provide. One example is from a safety net hospital, the University Medical Center of El Paso. This hospital used the mPINC survey and other resources to guide implementation of improvements in their maternity care and to serve as an external benchmark for monitoring these changes. One change was the creation of a paper record, which included components of the mPINC data used to improve patient care handoffs when mothers were transferred from labor and delivery to the mother-baby unit. This change, in addition to others, led to the hospital increasing their mPINC total score from 65 to 92 in just 2 years, and they saw a concurrent increase in their exclusive breastfeeding rate from 16 to 42%. Lastly, I wanted to highlight some work happening somewhat close to home in Mississippi. The Mississippi Communities and Hospitals Advancing Maternity Practices, or CHAMPS initiative, seeks to improve maternal and child health outcomes through the promotion of breastfeeding and baby-friendly practices across Mississippi. CHAMPS works with Mississippi birthing hospitals to help them meet the 10 steps to successful breastfeeding and work towards baby-friendly designation. Mississippi has 40 hospitals, 21 of which are now baby-friendly hospitals, with 19 of those 21 being supported by CHAMPS. Further, Blue Cross and Blue Shield of Mississippi partnered with the Mississippi State Department of Health and CHAMPS to assist their network hospitals in achieving the baby-friendly quality designation through education and training. We can see Mississippi's recent and quick progress documented by mPINC. 80% of Mississippi hospitals responded to the 2020 mPINC survey, and the state's total score was 83, which is 2 points above the national total score and a 10-point improvement from their 2018 total score. So to summarize what we have discussed today, state and local governments can support breastfeeding by adopting standards for hospitals to support breastfeeding, helping hospitals implement the 10 steps to successful breastfeeding, and helping hospitals connect mothers to community programs for support once they leave the hospital. Hospitals can support breastfeeding by implementing the 10 steps to successful breastfeeding and work towards achieving baby-friendly designation. Hospitals can also use the data available to them, including mPINC, birth certificate, and newborn screening data, to improve maternity care practices that support breastfeeding. Hospitals can also work with doctors, nurses, lactation care providers, and organizations to create networks that provide clinic-based, at-home, or community breastfeeding support for mothers. Healthcare providers can help write hospital policies that support mothers and babies to breastfeed. They can counsel mothers on breastfeeding during prenatal visits. Healthcare providers should ensure they have sufficient knowledge of and stay up to date on current infant feeding guidelines and recommendations so they can pass along the best information to their patients. Providers should include lactation care providers and other breastfeeding experts on patient care teams. And lastly, providers can support breastfeeding in the hospital and at well baby visits. So in conclusion, whether your work is at the hospital, community, or governmental level, there are steps you can take to use these data for action to improve the health of infants and families. First, know your hospital or state mPINC scores and share them with key people in your organization. Next, use that information to identify both areas of success as well as areas for improvement to inform future work. You can also encourage hospitals to participate in mPINC. The more participants, the more accurate a picture it provides of maternity care practices across the US. And lastly, look out for the mPINC 2022 survey, which is scheduled to launch early next year. Thank you for your time today. Please feel free to reach out to our team with any questions. You can also join our mPINC listserv to receive periodic updates about the survey. If you would like to sign up, please email mpinc@cdc.gov. Thank you again.